So this is pretty much the same talk I gave last year. I am lucky because that was in California and very few people who are there are here. It is really geared more toward if you have a new diagnosis or a first-time attendee. If it's not your first conference, you listen to this whole talk and you don't learn a thing, that's fantastic because it means you know what you need to know. I am happy to email these slides or Ken can post them. There are a bunch of references at the end, so if you want to download an article, give it to your doctor, it's there for you to do so. And Jenny was absolutely right. My story is that, I trained at this big children's hospital, think I really know something. I practiced for 12 years before I joined the FDA, and when Wendy got tested, Jenny had a complicated pregnancy. They lost the testing first, kind of typical of the medical system, and a lot of what I do professionally now is looking at the patient-unfriendly and hazardous things the medical system does that works not in favor of patients. So it was a great example of that. That got lost. Then they found it. It was a Tuesday morning. I used to work Tuesday afternoons and evenings. I was on my way to Home Depot when my cell phone rings, and the geneticist talks to Jenny and I while Jenny's in the office, and I'm have them on speakerphone, and I'd never heard of the syndrome, so I don't know anything. And 1p36 is new enough, and I'm old enough that it wasn't even in my genetics book because they hadn't written it and put it in the book when I bought my book and 15 years had gone by. So I've read most of what's out there. I'm going to try to share the big picture stuff with you guys now. So always disclaimers. I work for the FDA. This is not a work-related talk. So, hey, the opinions here are mine. Don't confuse those with those of the FDA or the government. They make me put that in there. And look, I want to say this is a presentation of medical findings and descriptions. Don't use this as medical advice. And by that, I mean I don't carry malpractice anymore. So it's not worth you suing me. So please don't act on the advice. If you want to go and talk to your doctor, great. But every patient's situation is different. It's unique. Your kid's on different medicines, has different health issues. There's no substitute for like a good, serious discussion with a competent person. I have no financial conflicts. Everybody knows that I have a daughter with 1p36. So what do I want to do? I want to give you some basic information. I want to talk a little bit about medical needs, give you some ideas of ways you can help. And I think what I want to do here is provide a realistic picture tempered by hope. You've just seen Callie, who is really, really far ahead of many, many 1p36ers. I don't know of anybody that's exactly like Callie and has her abilities, but that doesn't mean that some other 2 or 3-year-old or newborn in this room isn't the next Callie. It also doesn't mean that just because your kid's not the next Callie, that they don't have really good abilities that we can work with and help them develop to whatever their maximum potential is. But I think it's sort of important also to keep in mind that the limitations we're dealing with. So realism tempered with hope. So look, if you're recently diagnosed, this is pretty overwhelming, it's frightening, it's confusing, but it will be okay. Pretty much everybody in this room has had this terrible moment happen to them, and we've all survived and come through it generally better, but we all have some scars. And there's 200 people in this room who probably can answer your question in one form or another. And throughout this, I just throw in some pictures. I think this is Tennessee and Ohio on the Mom's Night Out. So let's do basic biology. So in each of our cells, we have 46 chromosomes. They're divided into 23 pairs. So you have 2 1s, 2 number 2s, 2 number 3s. And whenever geneticists lay this out, they like to do them largest to smallest. And that one is number 1, because it's the biggest. So if we blow up chromosome 1 really, really, really big, and we look at this, and you stain it with special dyes and such, they have these stripes. They're called bands. So what 1p36 means is P is the short arm, Q is long arm. No one seems to know why. But P is long arm. So chromosome 1, short arm, that's P. And we're talking about band 3, subband 6. That's that tiny, tiny, tiny little piece at the end. In the grand scheme of all of your DNA, it is a very small piece. But it is a very important piece. What we're learning is that we all have a lot of junk DNA. We have a lot of DNA, it just doesn't do anything. You could lose it, and it doesn't matter. You could have extra copies of it, it doesn't matter. Or maybe the consequence there is really, really small. But the 1p36 region is really, really full of genes that do important things. Keep in mind, this deletion is not the exact same in every kid. It's probably somewhere between about 1 million and about 7 million little pieces, little base pairs of DNA. But just because you have a similar piece that's missing doesn't mean those two kids turn out the same. If you go on the unique site and you look at people who've described your kid's deletion, you know, given the sophisticated testing that we have, sometimes they're very, very different. So I don't know that it's particularly useful to say, oh, my kid has the same deletion as this person, therefore they're going to have the same issues or not have the same issues. It doesn't seem to work exactly that way. Now, maybe that's because with some of the older techniques, we can't measure exactly where that's broken and exactly what's missing. But I'm not sure that even if we could measure that down to the smallest part, that would exactly help us predict. We're working to get there. When you hear Dr. Daryl Scott sit at the panel discussion tomorrow, this is kind of what he does professionally. He'll talk about some of those things, but we're not at the point where we can just say, you're missing this piece, this is what it means. And then just terminology-wise, right? If it's at the very tip of the chromosome, that's called terminal. It's at the terminus, the end of the line of the chromosome. If the end is still there, but it's missing a little piece before that in the middle somewhere, that's called an interstitial deletion. I also don't know that that's terribly important, except when you get your report, it'll say ter and then have a whole bunch of letters and numbers, which just means it's from the end and going back toward the middle. That's all that means. And again, I'm not sure that that's terribly important, because to me what's important is what are the health issues this kid is having, not so much what piece of DNA is missing. Long term, to help us all figure out what these things mean, that's important. But for today, I'm not sure that that's really, really important at all. So let's just do some FAQs, because these are the things that people always ask me, and new families often ask. Does it have another name? A lot of diseases are named after someone, either the first patient or the doctor who described it. No such luck for us. It's sometimes called monosomy 1p36. It simply means you have one copy of that region instead of two. But medically speaking, it's the same thing. Whether you call it 1p36 deletion or monosomy 1p36, all the same. So how common is it? In terms of genetic things, it's pretty common. There are genetic diseases that are 1 in 1 million, 1 in 500,000, or that you only see in certain populations. The Amish, French Canadians, those sorts of things. This one's pretty common, 1 in 5 to 10,000 live births. So, and probably the most common chromosome deletion that happens at the end of a chromosome. There are probably a lot of people, particularly if they're older adults, who've never been diagnosed, because sometimes before these sophisticated genetic testing became common, maybe 10, 15 years ago, you would know as a physician, this person had a certain set of problems. They looked a certain way. They looked like they had a genetic thing, but you could just never figure it out. And so there may be plenty of older adults out there that have this, that just don't have this name or this diagnosis. Now, because testing is so good, I think we're finding that kids are getting younger and younger. Even with Wendy being 8.5, at that time when I went to conferences, new diagnoses were coming in. Kids were teenagers or preschoolers. Now we're seeing newborns because they're getting testing that much sooner. So, you know, there's probably a lot of people out there. I think if we added up everybody that belongs to the Facebook group, we would probably see that in the end that we have several hundred different kids just between, you know, the different Facebook groups that are out there. So there are a lot of people if you total them all up and total everybody who's been to a conference. Interestingly, and I don't know that anybody can explain this, it's about 2 to 1 female. That's a little bit unusual. And, you know, I've talked to Dr. Hopkin and Dr. Scott who'll be here. I don't think any of us have an easy, reasonable explanation for why that's true, but it's female predominant. Can you fix it? No. And I don't think we're going to be able to fix this for the simple reason of you're talking about dozens or 100 or more genes that are missing. So you're talking about a fairly large, complex thing that is missing. And you'd have to put that back into every cell where it affects an organ. You would need to put that back into every brain cell, every heart cell, every kidney cell, everything involved in hearing and vision. And I don't think we'll ever get there in my lifetime in terms of that kind of technology. We're still working with disorders that use one gene that's a problem. And we're still trying to fix those. And honestly, we haven't done that well. We're still working on trying to fix genetic syndromes that are caused by a single gene. So I don't think you can fix it. I do think there are many, many things you can do to help your kid and advocate for your kid, much as Callie said. And I'm going to make this point over and over. Therapy, therapy, therapy. Whether that's physical therapy, speech therapy, any intervention is probably a good thing. Take all the support and the help you can get. Okay, is it your fault? No. This just happens. About 90 to 95% of the time, you have normal chromosomes, your spouse has normal chromosomes, and this just is a freak biologic thing that happens. Sometimes things go wrong. However, in about 5 to 10% of cases, there's something called a balanced translocation. If you look at the little graphic, you got like a blue and like an orange chromosome. And part of the orange is stuck to the blue, part of the blue is stuck to the orange. In that case, you still have 2 copies of everything. As long as you have 2 copies of everything, you are okay. So even though those chromosomes are mixed up, as long as you don't have 3 of anything, and you don't have 1 of anything, and you have 2 of exactly everything, you're fine. However, you know, when you go to have kids, they either get the all blue or the all orange, which is fine, or they get the one that's mostly blue, and they're going to be missing part of blue, or they're going to get the one that's mostly orange, and then they're going to be missing some orange and have too much blue. That's when there's a problem. So if you have a balanced translocation, you would be perfectly normal, but half or more of your kids, thereabouts statistically, would have some sort of genetic syndrome, be it 1p36 or something different. So I think what this translates to is, when do you need to have your chromosomes checked? If you have a 1p36 kid and you're thinking about additional children, you need to do that. If you're not going to have any more kids, I don't know if it's terribly important. If you are the sibling of a 1p36er and you're thinking about having children and you don't know if your parents have normal chromosomes, then that's important. So perhaps one reason, if you're not going to have any more kids and you want to have your chromosomes checked, is for the benefit of your other typical children to know if they're at risk. That would be one advantage. So what does this mean? All kids with 1p36, obviously you look around this room, we all know this, have many issues in common. Similar facial features, some degree of intellectual disability, low muscle tone. Those are pretty much universal. But keep in mind, not every kid has every feature. Not every kid has seizures, many do. Not every kid has problems with their heart, but many do. But in general, when you have one of these deletion syndromes, the kids will have a similar set of problems. Not every kid has every problem, but you could list out those problems and say, kids with this syndrome are at risk for these things. However, as I said before, at present, we can't just look at your kid and their chromosomes and say, this is what they're likely to have issues with. And actually, Callie mentioned Molly Mendoza. Molly is the young woman with red hair on the top part of the picture there on the left-hand side. So, common features, and I don't just show this so I show pictures of my kid, but I have easy access to many pictures of my kid. I think we talked about kids with a genetic syndrome have common features. So you can look at your child and other kids in the room, and they look more alike than they look like their own family members. And one thing you see are very straight eyebrows. Almost everybody has some curve to their eyebrows. 1p36 kids don't. And they're also just maybe a tad lower than most of ours, so they sit sort of right on that bony ridge. They have these really deep set eyes. They have kind of a flat bridge of their nose, this small pointy chin. All of that is well described out there in the published medical literature. What's not described, but I think we would all agree, is that they have lots of bushy hair, okay? So even though that's not in the article in the journals, I think clearly that is a component of this syndrome. We can look around the room and see that kids share these features in common. I want to show you Wendy at different ages so you can see that as kids grow, these things really don't change very much. In this picture, I think Wendy is about 6.5. That's Wendy at 2. Straight eyebrows, deep set eyes, pointy chin, flat part of their nose, lots of bushy hair. There's Wendy about 3 weeks ago. Straight eyebrows, deep set eyes, flat kind of nasal bridge, still pointy chin, although you can see that between 2 years ago and now she's developed a fondness for ice cream and her face is a little fuller. So it's harder to see that pointy chin, but it's there. And still lots of bushy hair. She gets her hair cut like every 3 weeks. All right, intellectual disability. I mean, this is the big battle that, right, we're really all fighting. All kids have some degree of intellectual disability, but I think you can see right? Callie gets up here and gives a 10-minute speech. Now, Callie works on that speech for months, and she does it over and over, and she works really hard. But she does it, and she can do it, and she does a great job. But it's tough, much tougher than me standing up here. I mean, I can stand up here and just blab for 10 minutes, no problem. She has to really work at it. And I think this is true for every skill for 1p36er, from rolling over to walking to speech. It's really a slow go, but they can get there. We can't predict the severity of that intellectual disability. Nearly all kids require some education support, special education services. And I think it would be fair to say that even adults with 1p36 need some assistance with their activities of daily living. So I think the idea that 1p36ers grow up and are going to get married and be completely normal and function independently, I don't know of anyone like that. Certainly Callie does a great job, you know, but she still needs support, and she'd be the first one to tell you that. So I think you have to long-range plan and think about that this is not going to be someone that is eventually going to grow up and leave your home at, you know, 35, like so many kids today. The other issue, low muscle tone. Yeah, I don't have a lot of applause lines like Callie, but I throw in sarcasm every once in a while. Low muscle tone. I think this is really a big issue early on, because this is really a tough thing for physical development. It is hard to coordinate things like eating and swallowing. So feeding issues are often a problem in infancy. I, for the first 3 months, basically held Wendy's face like this so that she could suck a bottle and form a seal around a bottle, because her tone was very low. So it can also be an issue with swallowing. And obviously it contributes to difficulty with physical skills. What you have to remember here is tone is the tension in your muscles at rest. So these kids are very floppy. That is a completely different concept than strength, which is the amount of force you can exert when you're working muscles at their hardest, okay? Wendy has really low tone. If you hold her or she's asleep, she'll just flop down. But sometimes it takes two of us laying on top of her to change her diaper if she's really fighting, because she is incredibly strong, even though she is 52 pounds. So low tone doesn't mean weak, okay? It means low tension in your muscles at rest. Tone can't really be changed. It is what it is. But as you build strength, you can do things like hold your trunk upright rather than flop over when you can't sit independently. So things like physical therapy and occupational therapy become important for building trunk control and fine motor coordination. So again, therapy, therapy, therapy. Early intervention. I think I mentioned it later slide, but there is a federal law that says all kids with disabilities and delay younger than age 3 are entitled to free services. Like, however you access that in your state may be different, but take advantage of that if you have a young kid with 1p36, because it's at no cost to you, and therapy, therapy, therapy is really important. Okay, heart defects. So heart defects means the heart not put together in terms of its structure in the right way. Okay, so it's not built right. About half the kids to maybe 3/4. The most common is something called an ASD or VSD. They're simply holes in the middle wall of the heart. Sometimes they're important, sometimes they're small and they're not important, but they're often there, okay? So getting an echocardiogram to look at that is important. If it's normal in terms of how the heart is built, that's not gonna change. So that's one of those where sometimes you can check the box and then forget about it if your kid is normal. But if there is some sort of defect, you need to have that followed by a cardiologist. In a minute, I'm gonna talk about the heart as a pump and how the heart functions. That's sort of a little different ballgame, and we'll get to that in another slide or two. So seizures. Think this is really a battle that lots and lots of parents fight with, because seizures are sort of terrifying to see. I don't like to see kids seize, and right, I mean, I did pediatrics for 20 years. It still creeps me out. But about half the kids have it. Often, if your kid is going to have seizures, it's typically going to start before the second birthday, but it doesn't always. There's a report in the literature of a kid who had their first seizure at 15, so I don't think you can always say, oh, my kid's never going to have seizures. Most of the time, about 2/3 of the time, can be well controlled with medication, and we have more seizure medicines available now than we've ever had. In 20 years ago, there hadn't been a new seizure medicine in 30 or 40 years. There have been a couple of dozen that have come out in the last 2 decades. So we have a lot of options. That being said, about 1/3 of kids, we can't get good seizure control in them. And some of our kids just have very difficult to control seizure disorders. And I think you just keep trying different medicines and different combinations of medicine, but realize that's one of the things that is really, we would like to have more knowledge and more studies in that area. We don't have anything really published out there on what works best, but people just have to keep trying different things and see what works for your kid. I think because seizures are not always physically easy to recognize, you do an EEG test in infants, and that will say if they're having seizures or if you suspect they had a seizure. And in general, uncontrolled or prolonged seizures are bad for your brain and bad for development. One seizure isn't necessarily a big deal, but many seizures or very long seizures are a big deal. So good seizure control is a very important thing. So hearing and vision. Obviously in infancy, this can be a little bit difficult to measure, but somewhere, half, 2/3 of the kids have some hearing loss, so a hearing evaluation is important. Hearing aids certainly can be helpful. And obviously, it sort of goes without saying, good hearing is important for speech development. And clearly, spoken language is one of the things that is most difficult for our kids. Many of them get around, but even the ones who are doing well in terms of intellectual development often have a lot of trouble with speech. Now, there are many ways you can communicate. Paige has her talker, and my daughter uses an iPad sometimes, or you can sign. But just keep in mind, hearing is important there, no matter how you're going to communicate in the end. Vision or eye problems, again, in about half. And these things tend to be things that are easily correctable, like just the need for glasses or drops or that kind of thing, but obviously also important to have them checked. So cardiomyopathy, this is the other part of the heart issue. So part of it is structural. Is your heart built the right way? The issue here is, does your heart work as a machine the right way? Does it squeeze like it should? So this occurs in about 1/3, although keep in mind all the numbers I'm giving you come from one study where there were 60 kids. There are about 60 1P families in this room. So the largest study ever performed on 1p36 to describe all this basically is the equivalent of a very good survey of everyone at a 1p36 conference. That's what we know. So knowledge is very limited. It's a really good start, but it's not perfect. So we think about 1/3. It can happen at any time in infancy or adulthood. The tricky thing with cardiomyopathy is, unless your heart is in very, very bad shape and working very poorly, there's not going to be any outward sign. So it's not something that you can look at somebody and know. And it is treatable with medications. So I think the thing is, cardiology evaluation infancy, echo every couple of years to make sure the heart is pumping as it should. And that's based on a recommendation done by a woman named Ashley Brazil, who worked with Robert Hopkin, who will be here. And she looked at kids who are 12 years and older and sort of did a survey of saying, what is the quality of life and the medical issues that preteens and teens with 1p36 have? And I would just say that we need more studies to understand this, because we don't really have a good description of the cardiomyopathy issue, how common it is, how severe it is, and how we should best treat it. So skeletal defects, meaning bones, okay? Happens in about 40% of kids. This could be everything from a delayed bone age, which sort of means like you're 12, but your bones look like they're 8. Scoliosis, which is the big one, which is curvature of the spine. And you can have rib abnormalities, like some kids don't have a 12th rib, or they have a 12th rib on one side and not on the other. That's generally not important, okay? You're never going to know if you have a 12th rib or not. It doesn't really do anything. It's not going to harm you in any way. I think scoliosis there is the big issue, and in my experience, tends to occur more commonly in the kids who are in wheelchairs, because obviously they're not up and moving around. They're exerting the same kind of pressure on their spine all the time. And that can be a really big issue, because if your spine curves enough, it can impair your ability to breathe and get air in and out, and often requires surgery, and the surgery is a pretty big deal. So keeping an eye for the scoliosis issue is probably the biggest bony thing. So genital urinary abnormalities, meaning the genitals in the urinary system, they're found in about 1/5. This can be little kidney defects, can be defects of the uterus or the external genitalia, missing testicle, that kind of thing. Kidney defects can lead to frequent urinary tract infections and problems with kidney function. So probably an ultrasound of the kidneys, non-invasive, not painful, is probably a reasonable thing to do. And if the kidneys are normal, then you can kind of check that box and forget about it too. Behavior issues. This is a giant mess. And following me, we're going to have 2 people from Kennedy Krieger come up and talk who are masters of this. And we're lucky in Baltimore to have access to that kind of expertise. I think it goes without saying, these can be severe. and they can really seriously impair your quality of life. About one every 2 weeks, Wendy likes to get up between 1 and 3 a.m., and her favorite thing to do is run around the house, scream, and slam doors. And I don't care where you are in my house, it is not quiet, and there is, nothing you can do that's going to get her back to sleep. And then the other 13 nights, or 29 nights out of the month, she sleeps through and she's great. I don't know what makes that one night happen, and it's hellish. But that's why we're doing a lot of therapy. And there are different issues for different kids, right? Self-injurious behavior like biting on the wrists, just being disruptive or having meltdowns. And obviously, as your kid gets older and physically bigger, it's a bigger issue. So I'd say about half the kids have this, though I suspect that that's kind of an underestimate. And some of the other kind of things are there. Excessive eating was described in 13% of the kids in that article. I think it may be a little higher than that given my experience, but that's just my own 2 cents. And I say, look, therapy, time-consuming, certainly. Prolonged, absolutely necessary. Can it be expensive? Yeah, it depends on your insurance. Can it vastly improve your quality of life and maintain your sanity? Yes. So is it a big commitment? Yeah, but it's probably not going to get better on its own. So look, beyond the article in 2008, there is very little research about behavior in 1p36 kids, and even there, everything in that article is about 2 whole paragraphs. But clearly, behavior and sleep issues are really common. But which behaviors and how common? Not well described. So Drs. O'Connor and Dumstrup, who are going to come up here and talk, are going to give us some insight and sort of help us start to figure out some of these issues. Speech and communication, expressive language, meaning not understanding what people say, but saying things back to them. Clearly one of the most difficult areas. And expressive language also counts as sign or using your iPad or assistive communication device. About 50% of 1p36ers in that 12 and over study were nonverbal, but about a third used 100 or more words. And I think what that says is, like many issues, it is incredibly variable from kid to kid. And this is one of the maybe difficult or disconcerting things is, there's a wide range here of what our kids can do. So it's very hard if you have an infant to say, this is what we would expect. Because it could be anything from being nonverbal to being callihoots. I think you should encourage them to communicate, and people would talk all day and are more experts than I am, but I just try to encourage my daughter to use whatever form of communication she wants to use. She wants to sign, if she wants to use her iPad, if she wants to talk, I don't really care as long as she gets her point across. I mean, to me, I want to be able to meet her needs, however she does that. And I think if you stop and take the time to get to know these kids as we do, many of them communicate quite effectively. But the rest of the world, seemingly to me, doesn't like to take the amount of time it takes to listen and pay attention to see what these kids want. I mean, you can hold up 2 shirts and say, Wendy, you want to wear the pink one or the blue one? She'll pick. But you got to be patient, and you got to wait for her to do it, and some days she won't. But it takes a little time. It's just not easy when you got to make the bus in the morning. But I would just say speech therapy, trying to figure out, trying different things, get whatever help you can to figure out the communication issues. Again, development varies widely. I don't think there's any normal range here or what to expect. And we don't have any good way of knowing how your particular kid or any particular child will turn out. So again, therapy, therapy, therapy. And I would simply argue living your life and getting them out there in the world is really important. Let them experience things. So everybody wants some kind of range, what's expected. So here's the best we can say. In one study, about 80% of the kids walked. They walked between 6 months and 8 years. I've never seen many kids, normal or otherwise, walk at 6 months, but that's what was reported. Wendy walked at 3.5, but I think most of them are fairly delayed because normal walking typically be about a year. About 44% with first words, again, 9 months to 12 years. You will hear people tell stories of, I had a kid who was 10 or 15 and started to develop words when she's never done that before. And about half had some degree of toilet training. So medical care. Will your doctor have heard of this? Probably not, especially if they're over 40, because that means that they did their training like me and finished everything before this was even out there in the world and really described. So they probably will not have heard of it. But there are resources they can get to. If you have the internet, as nearly everyone does, you can find out about this. You can go to the 1p36dsa.org site. There's a chapter in something called Gene Reviews that you can pull up. The URL is there. And I have some other references at the end. Honestly, doctors tend to be really busy. Really good ones will go look. But if you can get a copy of the article and stick it in their hands, then they have something physical that they either have to put on their desk, eventually read, or they have to throw away. And none of us like to throw stuff away. So chances are they will probably at least read the beginning of it. So I would say if you can, stick papers in their hand. I know it's old school, but that way you know they have it if they want it, and they don't even have to boot up their computer. You need a really good doctor. I don't think that matters if it's a pediatrician or a geneticist. The more important thing is it's someone who will take the time to coordinate between all the different people. That's what really takes the time, and that's what our medical system works against at every turn. Doctors communicating with doctors communicating with therapists, and vice versa is very difficult. It's hard to talk to each other. So if you have someone that's willing to play that role, that's the person you want. It doesn't take a lot of expertise. It takes patience and time and effort. And that's the hard part. I give you a whole list. You can actually look up, there's a reference at the end of things they sort of recommend, not based on like huge studies, because again, 60 kids, but what you should do. So obviously the things you would think about: monitoring growth, cardiology we talked about, EEG in terms of seizures, thyroid tests, because some kids have thyroid problems. Getting a geneticist involved is always a good idea. At least for us, our geneticist was able to get us in to see cardiology and recommend a pediatric dentist, which we had really trouble accessing, and she was great. Hearing and vision, feeding and swallowing if that's an issue. Obviously, education in the school and placement becomes a huge issue as kids get to school age. And honestly, anything else your doctor's concerned about. But there are a lot of these things. So what can you do? Again, therapy, therapy, therapy. Be an advocate for their medical care. And I would say, look, keep detailed records of every visit and all the test results to the extent that you can, because what that allows you to do is you to be that communication person between them. They say, oh, well, what did they show when they did lab work? Oh, here, I have a copy. Because the chance, you know, the ER will say they're going to send a copy. ERs never send medical records to doctors. It does not happen. Even in this day of electronic medical records, it still does not typically happen. Okay, unless they're all at the same hospital. But if you go see somebody at University of Maryland and your doctor's out there in practice somewhere in the county, they're not going to get those records. So tips for productive visits. Okay, have a list of questions, put the important ones first. Get the important ones out there. Make sure that the office schedules enough time. The person at the front desk is going to have no idea what 1p36 is. They're not going to know how much time you need. Just tell them, I'm going to need more time. And look, be organized to the extent that you can. I don't want to give you 5 more things to do because their lives are already busy, and it's enough just the fact that like people got here and managed to eat breakfast and get their kids like dressed and changed and here. But I'm going to give you more things anyway. If you can just keep a binder with like weight, height, insurance info, name and contact number of all the specialists, date of that last visit to the specialist and what you talked about, test and test results if you can get them. That's a little bit easier now. I think there are many portals where you can get lab results and that kind of thing. List of medications, how often you give them, how much you give them, and what are the problems that you're currently looking into right now. Are studies being done? The answer is yes, but the progress is slow. There are many diseases out there. People generally like diseases that are kind of fixable, right? Nobody's going to develop a medicine that fixes 1p36. So there's just a lot we don't know. There is some research being done, right? Every year there's 5, 6 articles come out, but it's sort of in drips and drabs. How can we promote that? Participating in studies, right? You can't have a study of a lot of kids unless a lot of kids agree to participate. And at this stage, mostly, you know, we're not looking at doing invasive things to kids. We're looking at things like doing surveys and monitoring their heart function. Obviously, promoting awareness, raising the profile of 1p36 helps spark interest in donations. Wear your shirt to the Oriole game tonight, right? I'm gonna say, who are all those people wearing purple shirts? Fundraising. Research is incredibly expensive. Even a simple study can be $20,000, $30,000, $50,000. And that's like bottom of the line simple study. So I always say, if you are wealthy, famous, or politically influential, see Ken. Diseases get attention because famous people are affected by them, or a congressperson is affected by them. And is that just? No, but it's the way the world works. Resources. The 1p36 DSA site is really quite good, and if you go there, there are links to various sources of information. If you're looking for, hey, has your kid ever done this, and what did you do, and how did it work, and what kind of bed does your kid sleep in, the Facebook, is a really good, the Facebook group is a really good source for that. And then the issue where I was describing a list of follow-up issues, there's the URL there. So I want to finish with 7 things I've learned from Wendy, because I don't want to end on kind of a downer note. I will just say, first of all, I'd never heard of 1p36, as I said at the beginning. In practice, I think I was perfectly adequate with my special needs kids. I don't think I was particularly good at it. I'm not a very patient person. No, I'm an incredibly impatient person, and I just like to fix things. So I went into pediatrics because kids are fixable generally, right? Get an ear infection, take a medicine, 10 days, you're better, right? It's not like high blood pressure and obesity and diabetes and all that adult stuff that we get because we don't take good care of ourselves. I hate that. So I went into peds because kids are fun and they're fixable. So I don't think I was really good. I think I was adequate at my chronic special needs kids because it just isn't something I gravitate to. So literally, I think I would say that Wendy, both physically and emotionally, has beat the hell out of me and made me a person who is better with these kids. But that's only through her incredible persistence at shaping me. So 7 things I've learned from Wendy. 1, laugh even if you don't know what's funny. For some reason, our kids do enjoy really sadistic videos of kids being injured or people crying. My other daughter hurts herself and cries, and Wendy laughs and laughs and laughs. But sometimes Wendy just laughs, and I don't even know why, but she's got a great laugh. They all do, and it's fun. 2, and I think this gets back to Callie's presentation. Don't decide what I can and can't do. Let me try and try again. It may take a while, but most times I will succeed. It took, I don't know how many months of PT for Wendy to crawl upstairs. And then one day she did it. And then thereafter, she did it all the time, like it was nothing. Like she'd known how to do it her whole life. So I think it's just work at it. And if I do fail this time, so what? I'm not physically or emotionally made of glass. Failure is part of everybody's life, and we all fail sometimes. And I think Wendy would say, I'm probably more resilient than you are. I think, I've watched Wendy struggle with things and not get it and get angry and throw a tantrum, come back the next day, and just keep doing it. So I think, it's okay for them to be frustrated and fail because we all learn through trial and error sometimes. I want to see and do things like every other kid. It's okay if I fall or eat a handful of dirt, etc. Help me get out there and try. I think sometimes we say, oh my goodness, this kid is special, and we should surround them and protect them from the world. I think to a certain extent that's true. I also think you should go out there and let them skin up their knees and get dirty, because that's what kids do too. Developmental delay does not mean you're innocent. Probably a good lead into the next behavior talk. Wendy is as sneaky and as manipulative as they come. Do not mistake cute and delayed for naive and innocent. She is manipulative, and I just told the people in daycare, stand somebody by the door, because as soon as you turn your back, she is going to run. There is no question. In many ways, she is very impaired. When it comes to running away, sneaking out, or getting what she wants, she's incredibly sophisticated. I understand more than you think I do. I will do things you never thought I would do. I am always watching and listening. Don't give up on me. And I think that's true for our kids. Some days we forget that and get discouraged, but it's important to remember. And lastly, sometimes your child is going to drink from the dog bowl. Pick her up, dry her face, move on, okay? She's not gonna die, it's kind of gross, whatever. Happens at my house like 6 times a day, so either my dog is gonna die of dehydration or my kid's gonna drink from the dog bowl. I love my dog, I'm not gonna let the dog die. So, I wipe her off, I put the bowl up for 10 minutes, she leaves the room, I put it back down. It happens, whatever. I don't want to stay up here and answer questions now simply because I don't want us to fall behind. I guess maybe we have like a couple of questions if you want to. Here are the references. I will make these slides available, or if you want me to email them to you, I'm happy to do it. It's not like I'm going to sell this. It's not proprietary intellectual property. If you want to do a couple of questions, we can do a couple of minutes. I just want to make sure we get to the you know, the 11 o'clock presentation and don't get behind. But I thank you for your time. And again, if you want to curbside me anywhere in the next couple days, I'm happy to do that. Thanks. Anybody want to be brave and come up and throw a question at me? Last chance. I can take a mic to them if they don't. Ken will bring a mic to you, so you don't even have to come up. If you were a sibling and you are going on the Dave & Buster's trip, you need to go downstairs to the lobby now, or you will have to listen to people stand up here and talk for 3 more hours. Go down now. You will have cake. You will have pizza. You will have fun. All right. Ken will bring a mic. Ken, there's a question in the back.
I noticed on your graph that the now I got stage fright. That in 2014 there was a lot more investigation than in 2016. I wonder if there's a reason for that falling off.
It just depends on when people get their study published. So publication is kind of this game, right? You do a study, you have it ready, and you say, okay, I'm going to try to publish this in the New England Journal of Medicine. And they say, this is crap, we don't want it. And so then you say, okay, well now I'm going to try to publish it in the next most prestigious journal, and they reject it. And then eventually you get down to some other journal, and they say, okay, we'll publish it. So even though something's published in 2014, that work may have been done in 2011 or 12. So it takes a long time, and there's sort of this competing game. But really, what I did there is just look at in what year did that article come out, whether it was 14, 15, 16. I think the important thing there is not whether there was more in 16 or 14. The important thing is if you look over the last 15 years, that trend is upward with, you know, starting at 1 or 2 a year and now looking about 4 or 5 a year. So in any given year, you know, it's just how I divided it up and looked at the publications. I don't think it's gone down one year versus another. I think there's increasing interest, but I don't know that we're going to see another big jump in increase, again, unless there's some reason, generally financial, for people to be interested in it. Fire away.
On that same vein of testing, are there other deletions where studies can be done that aren't specific to 1p36 but still are beneficial to us?
Yeah, sure. There are lots of genetic diseases, and some of them have overlap, like with cardiomyopathy or seizure disorders. And look, there's no particular reason to think that kids with 1p36, that their seizures are different than kids with some other syndrome. And frequently the same medicines work. So that's sort of how people treat these things, and say, well, I'm familiar with kids with this other syndrome. These are the medicines that seem to work there. We're going to try this particular combination over here. So I think there are things you can learn, and there are things that are beneficial, right? To a certain extent, you know, the kind of cardiomyopathy our kids get also occurs in other syndromes, so you tend to treat it the same way. Would it be nice to have a study of all 1p36 kids with cardiomyopathy? Yes, that would be ideal. But that doesn't mean you can't learn from other ones or treat it the same way, because a lot of times, you know, if you're treating the same physical problem, whether it's caused by this syndrome or that syndrome, the same drugs work.
And by the way, if you look at your itinerary for tomorrow, we'll have 2 geneticists here and like a panel discussion, and one's a researcher. Some of that research questions they could probably answer even better.
Because that's what they do all day, every day. I just play a researcher for the Food and Drug Administration.
You recommended that we participate in studies. I'm wondering how you do that. My daughter was diagnosed by a geneticist at Hopkins, and all he said is, this is what she has, and didn't connect us with anyone as far as studies or anything, so.
Fair enough. Hey, you come to conferences, because sometimes we have people come to conferences and they pitch a study. Or you submit an email, and I didn't even plant that question. And you know, if we have your email, we can get in touch with you. But I think probably the most common way is through conferences, because I've gone around and tried to get people here and trying to get Wendy's cardiologist interested, maybe come to a future conference and do a study. So I think That's probably the easiest way. At these conferences, availability is not so much the issue, but with many rare diseases, I mean, no matter how big the medical center, whether you're Hopkins or the Mayo Clinic or whoever, you're not going to have 60 patients with 1P. It's just not that common. We have time for maybe one more question. All right, one more.
So we do a lot of therapies with Levihes too. We do a lot of Polish therapies and Hungarian therapies, and they're super helpful. But is there anything in the US that you're doing, a specific type of physiotherapy or speech and language that you found particularly useful that I could try and find in the UK?
I mean, I'm not a physical therapist by any means, but I think the issue is if it works for your kid or if they enjoy it, then I think it's great. Right? So hippotherapy is something a lot of people are into. I don't know that there's anything special about riding a horse except that it requires a lot of muscle coordination because you have to balance so you don't fall off the horse, right? And even if you can't do that independently, you're working all those muscles to try to do it. So whether that involves a horse or involves like you working with the kid on the living room floor, I don't know is terribly important. I think you do what the kid is interested in and likes if you can do that. And I think you do as many different kinds of things as you can because every different activity involves a different group of muscles, right? If any of you ski, but you don't ski all that often, you go ski and you hurt the next day because you used all these muscles you haven't used in a while. That's what different activities do. They use different groups of things. So I think the more things you can expose them to, even if that's just trying to walk around, going to the playground, whatever sort of therapy, I think therapy both formal and the informal of just living your life is really pretty important. Yeah.